Good morning, and welcome to the third in the series of improving treatment services for youth and young adults with opioid use disorders. I am very pleased today to welcome Dr. Grace Hennessy, our Associate Chief Medical Officer for Addiction Psychiatry, and our special guest, Dr. Marc Fishman from Johns Hopkins in Baltimore. Today, they're going to talk about family engagement and co-occurring disorders in this population. A couple of housekeeping things before we begin. The chat feature has been disabled. If you have any questions throughout the course of the conversation, please enter them into the question and answer box. We thank you all for your participation in this series, and we will be posting and sending out the links to the series shortly if you're looking to watch them again. So without further ado, I'm going to turn it over to Dr. Hennessy and Dr. Fishman, and thank our partners at the Partnership to End Addiction for all of their assistance with this series. Thank you.
Thank you very much. Hi, everyone. Thank you so much for attending today. If this is the first of the series you've attended, or if you have attended all three, we are really grateful that you gave your time to these important topics. Much like for those of you who were here last week, we're going to have a similar format where Dr. Marc Fishman will present some slides first, which will review some of the issues we discussed in the last 2 weeks regarding use of medication-assisted treatments and opioid use disorder in adolescents and youths. And then we will have a question and answer series. Just as Maria Morris said, please put your questions in the question and answer box. The chat box has been disabled. I will be monitoring the questions. And again, after Dr. Fishman presents, we will look at the questions that you have. I also have some that I have come up with, and we'll further discuss those issues. So thank you very much. And now I'll turn it over to Dr. Fishman.
All right, let me just make sure confirm that the sharing's working.
It's working. It's just we can see all your slides. It was like it was before when we did the first test run.
Let me try one more thing. Let's do this. And let's do. Well, no, I don't know what I'm doing.
So that's great. If you can drop
How about that?
That's better. You have on the side as your outline as well. Well, if you can, we don't want to hold up the presentation for too long. So if this works.
So let me just go. And anyway, so thanks so much for having me. A treat to be here. And I'm eager to get on to the discussion. But Dr. Hennessy, as she said, has asked me to present just some quick background information. We'll talk a little bit about the evidence base for the use of medications, and then talk about some issues around the engagement of youth and trying to improve retention and adherence, and some focus especially on family involvement. Think of this essentially as a reference resource, and you guys can have the slides and the references to be able to refer back to, so I'll go pretty quick. This is one of the great granddaddies of the research base that shows us that the use of MOUD or MAT, medications for OUD in youth, are safe and efficacious. This is the multi-site study led by George Woody's team through the Clinical Trials Network. My group was privileged to be one of these 7 sites. And fundamentally, this was a 12-week trial of counseling only versus 12 weeks of buprenorphine treatment plus counseling in adolescents and young adults. And as you can see, opioid positive urines reduce substantially during the course of treatment, then revert to the control after the treatment is over. So glass half full, you get this statistically significant and clinically substantially meaningful reduction from levels of, say, 90, 95% opioid positive urines in this high severity target group of youth, down to levels of perhaps 35%. Glass half empty, you notice it doesn't go to 0%, and there's certainly not curative, but we see safety, we see efficacy, and so that's been sustained in a relatively increasing body of research. Here's another important study. This is from Lisa Marsh's group. This was 1 month treatment versus 2 month treatment with buprenorphine, looking at 2-month outcomes, establishing a couple of important things. One is that longer is better, so duration of treatment for 2 months is better for 2-month outcomes. Putting people on 1 month of treatment and then tapering them does not do as well for retention, and then, although it's not shown, also for opioid positive urines. The second thing that was kind of an accident, because she shifted the requirements for treatment midway, so this isn't randomized as much as it's the first group, first half of the study versus the second half of the study, and this is shown on the left versus the right, is that initially they required daily attendance, thinking about safety and about diversion and about IRB requirements with a relatively new kind of treatment for youth. But they found that it was hard to recruit, so later in the study they lightened up and decreased the requirements from daily to maybe 2 or 3 days per week. And those that had these intermediate program requirements were retained in treatment significantly longer than the first set of participants who had very intensive and more restrictive program requirements. So there's this nice impact of treatment delivery demonstration. On the one hand, we want high intensity. On the one hand, we want very close monitoring. We certainly think of young people as needing the kind of structure and reinforcement and background delivery platform. On the other hand, there's probably a sweet spot past which it's too much to ask and you reduce engagement. I don't know how much you can decrease requirements and still maintain the kind of engagement that they got in the second half, but it just demonstrates that there is this impact and there's probably some balance.
Dr. Fishman,
Yes.
Hi, it's Dr. Hennessy. Sorry if I could interrupt. Perhaps if you tried use slideshow, would that make your slides appear? It's up on top of your
All right, let's
screen.
try that.
Sorry for interrupting.
No worries. Any help is good help. Just trying to figure out how to do that. I need to stop sharing, then I need to get here.
So while Dr. Fishman's trying to change his slides, I'll just remind everybody to please use the Q&A box if you have any questions for Dr. Fishman as the presentation goes along. And then hopefully we'll get a slightly better view of the slide shortly. And if not, we'll go back to what we were doing before. Thanks very much.
All right, is that better?
Much better. Thank you so much.
All right. Okay. So there is an emerging body of work and an established broad clinical consensus among experts about buprenorphine that I've shown you just 2 examples of. We can talk a little bit more about that. There's less information available in this particular youth target population about extended release naltrexone, but not none. And this was the first such example of that, a case series that our group published on our first 20 cases of extended release naltrexone with adolescents and young adults. And at 4 months, about half of them had good outcome. Hardly a randomized controlled trial, certainly more research and more demonstration needed. But again, a first indication that there's safety and efficacy and every reason to expect that the work that's been done and the extensive work that's been done in adults would extend pharmacologically to young people as well. This is a much bigger cohort. This is a multi-state Medicaid claims data set looking at 5,000 almost youth with a diagnosis of OUD at those that did receive treatment, divided naturalistically in those that received medication plus behavioral health services versus those that received no medication but behavioral health services only. And this is the survival curve of their retention, and those that received medication were retained substantially longer and in greater numbers, not just in medication treatment, but also in psychosocial treatment. So this is a nice indication that you don't have to choose. You can have your cake and eat it too, and that medication treatment improves retention and also improves retention in other much needed components of the broad, holistic, multimodality treatment set. So just to summarize the evidence, buprenorphine is effective. Unfortunately, the outcomes in youth are not as good as for older adults. I'll show you a little bit of data about that. Extended release naltrexone is promising, but there's unfortunately little youth-specific research. But as I said, every reason to suspect that at least from a pharmacological point of view, the results should be very similar as they are in older adults. Longer durations of treatment is better, so there is no evidence for some predetermined arbitrary time limitation. That is not to say that this has to be a lifetime treatment. That is not to say that this has to be a multi-decade treatment, but that in general, the notion of treating people, including adolescents and young adults, for as long as it takes to get them back on their feet and stabilized, rather than saying this will only be short, this will only be for 5 minutes, this will only be to get you through some predetermined arbitrary time. No evidence for that. Medication improves retention, and as I said, that includes non-medication treatment retention. So that's a way of improving engagement in a whole variety of different treatment modalities. Although one would wonder, and it's a reasonable question about any pediatric treatment, the good news is there has been no signal whatsoever so far that there are additional safety concerns based on age or developmental stage. That's not to say that these medicines or any medicine might not have side effects, but no additional side effects or no additional safety problems based on young age. And furthermore, the evidence and consensus really strongly supports that medications for OUD ought to be used as first line. And there's no evidence that there ought to be a fail first approach. That is, that young people ought to have a trial of non-medication treatment before they move on to medication treatment. And that's for a number of reasons. One is that medication treatment is so clearly more effective when used as a component in a multimodality treatment, but also think about what fail first means in OUD. Failing can be an overdose, failing can be a fatal overdose, and we certainly don't want to wait for that. So I don't mean to suggest, though, that all we need to do is spread the prescription pad, put buprenorphine or naltrexone in the water, and then all is done and OUD in youth is cured, right? If only it were that easy. It's certainly not. Those of you who work with young people certainly know that developmental vulnerability in terms of engagement, retention, and the many, many different kinds of goals for treatment as entry to the journey of recovery are so important. And you can think of all the barriers that you know about or might imagine if you don't have this experience, that young people consider themselves invincible, that they are surely immature in so many ways, that there are limitations to the appeal of treatment, there are limitations to their motivation, even more so than older adults, that they have less salience for the consequences of their OUD, and they very strongly feel the burdens of treatment even more than adults, and can think of many, many things that they'd rather be doing than sitting around in treatment, which they see often as being very lame. Family leverage can be very variable, and when we don't have special enhancements to try to improve family engagement or improve the effectiveness of family leverage, as we'll talk about a little bit, it can range from excellent to non-existent, and so that's a very important issue. There's also the issue of the developmentally normative pushback, especially among young adults, but also among adolescents, against their subjective sense that parents are over-intrusive, are over-restrictive, that despite maybe some sense that they might rely on the supports of their families, They don't like to see it that way. I'm 18 years and 1 day and I'm all grown up and you can't tell me anything and it's none of mom's business. And that'll be familiar to any of you who've worked with this target population. And then I can't emphasize enough how prominent comorbidity is. And if it's not 99%, well, then it's 98%, but it's nearly universal, right? Here is some work we published recently in the Journal of Adolescent Health. This is a secondary analysis from the XBot trial, which many of you will know about. Just briefly, it was a randomized trial in adults 18 and over, comparing extended release naltrexone versus sublingual buprenorphine for 6 months of treatment. And this secondary analysis compared retrospectively the 100 or so young adults 18 to 25 versus the older adults above the age of 26. And this survival curve very clearly demonstrates that the young adults do not do as well. So the 6 months non-relapse rates in young adults were 34% compared to the non-relapse rates in older adults of 49%. So glass half full, there is a good and robust response to these medication treatments in young adults, 34%, but glass half empty, it's not nearly as good as it is for older adults. So there is, despite the effectiveness, there is this differential where we can clearly have room for improvement. Just to make the point that it can be done in specialty treatment. Remember, that wasn't youth specialty treatment. That was all comers, adults in 8 or so specialty SUD settings around the country. This is work that we published about a specialty clinic where young adults selected to come following an acute episode of residential treatment, including detox, into a specialty youth medication for OUD IOP. So this is a bit cherry picked, right? These are not just all comers. These are youth who specifically said, I'm willing to come to a high intensity outpatient treatment that includes medication for OUD, be on one of these medications, that is buprenorphine or extended release naltrexone. And they also were people that had shown up for at least one episode of care. So it's a especially handpicked group of people. But the good news is that for both of these medicines, we had 6-month retention in this small naturalistic group of 40% at 6 months without any significant difference between buprenorphine and extended release naltrexone. And they were treated side by sides in the same group with their choice of medication. And so it can be done, and it can be done outside of boutique research in kind of a standard care setting in the real world for Medicaid pennies. On the other hand, remember that is a select group. And if you go further upstream in the cascade of care, so this is one step upstream, looking at people not who had necessarily agreed to come to IOP or had necessarily shown up to IOP, but who had received a referral to IOP. And the results are not as good because many of them don't show up. Many of them have lower motivation. One nice thing is in this naturalistic cohort, some did not accept a recommendation for medication. This is, again, not randomized, so it's naturalistic, so take it with a grain of salt. But the notion that those who accepted the treatment with medication in general did better than those did not. And those with medication did better in terms of first engagement in the outpatient treatment and in terms of the 3-month retention. On the other hand, here you see that the 3-month retention, which did converge between the two groups gradually, and there was substantial attrition over time, is at best in the 30% range at 3 months. That's not as good as the 40% at 6 months that I showed you before, again, going upstream. And then going even further upstream, here is a group of adolescents and young adults who were referred to any outpatient treatment, not just an integrated specialty youth OUD outpatient within the same system of care, but coming from an inpatient episode of acute treatment, including detox, to any community care. And one nice thing about this study was that we had a fairly large sample, the largest sample that I know of youth in OUD so far, 288. But the bad news is that although a third of them accepted a referral for extended release naltrexone and a third accepted a referral for buprenorphine, a third of them did not want any meds. But even among those who did accept meds and were started on meds in the acute residential episode, the follow-up attrition and dropout was enormous, alarmingly high. And so over the ensuing 6 months, those that were on extended release naltrexone only had 1.3 mean doses, with almost none of them getting all the doses, only 12% getting 3 outpatient doses out of 6. And buprenorphine didn't do much better, so that there were only 2 months of the ensuing 6 months of possible treatment that these young people were actually on medicines rather than dropped out and non-adherent. So in general, although I'm making the case that these treatments can be effective and ought to be a mainstay of treatment, we really don't do, in general, in usual care, a very good job of retention, adherence, and engagement. So the puzzle for us to think about today together and in the field in general, both in terms of innovations in clinical care and advances in clinical research, are how do you improve these outcomes through developmentally informed models of care. You heard those of you who were here with us last week heard Dr. Sharon Levy talk about bringing such care into primary care in a spoke and hub model. And so that's certainly one very promising innovation. I just want to mention some work that we're doing with a model that we call YOURS, or the Youth Opioid Recovery Support Intervention, with these 4 component elements: assertive outreach, heavy emphasis on family involvement, direct home delivery of extended release injectable medications, and then contingency management incentives for receipt of those medications. And I'll focus a bit on the home delivery and especially on the family engagement, since I think that that's a theme that we can generalize. That is, I'm doing this very high intensity, high resource need, funded by special research with grant dollars from NIH. Not everybody can easily do that. It's a heavy lift, but thinking about family engagement as a broad concept, I think, is much more generalizable and easily applicable to a whole variety of settings. One thing I think that is important, both in the work that you heard Dr. Levy talk about last week and you're hearing me talk about today, is to be very clear about the primary emphasis on medication as a cornerstone of treatment. I don't want to exaggerate, I don't want to overdo it. I don't mean the only component of treatment by any means. It is not sufficient, but it is necessary. And the reason to really think of it as the tip of the spear or the thin edge of the wedge are summarized here. First of all, very high effect sizes. Medication treatment is more effective than treatment without medication. It's very straightforward to understand the very important impact on prevention of overdose and death. Medication reduces barriers to care and increases retention. It emphasizes that immediate stabilization, as you get with medications, is a very important first step in the path to recovery. It may not do the whole job. It may not be sufficient, but it is necessary. And unless you can get these young people stabilized, it's very unlikely that you'll be able to retain them in treatment for the other critical elements to consolidate recovery. And then lastly, I think medicines are easy to conceptualize for patients and for families as a standard element of treatment for any relapsing, remitting chronic illness, and in the hands of families as you're trying to explain to them and encourage them to promote treatment. the idea that you'd go seek out healthcare with medical providers who might have an effective medicine for a chronic health condition makes sense. And it also makes sense in terms of how to try to help influence the care trajectory for a young person who may themselves not quite get it, who might not have a good path to care utilization. But every parent, or at least every mom, right, has had the experience of struggling with a 4-year-old or a 5-year-old with otitis and a fever and an earache and didn't want to take the icky pink medicine. And just being able to wrestle with that person, and of course it's easier to wrestle with a 5-year-old and basket hold them and squirt the medicine. That's different maybe from a 250-pound 21-year-old who doesn't want to take their OUD medicine. But the concept is very similar, right? A cranky, non-cooperative, sick young person who doesn't utilize healthcare, who doesn't get it, who doesn't see the need. And that's a perfect kind of role for a mom or a dad to take in terms of mobilizing their energies to promote treatment. Assertive treatment is a well-established kind of treatment modality. Those of you who know about assertive community treatment for the treatment of chronic schizophrenia or directly supervised and observed medication for TB, HIV. So we're borrowing from those playbooks. Family, which we'll just focus on as a last little chapter, but I think so important, has, I think, not been sufficiently incorporated into OUD treatment for youth and for SUD treatment broadly across all substances. And although we give lip service to addiction as a family disease, I don't think we actually put our money where our mouth is about actually implementing it. And we talked about the normative pushback by the youth against their sense of the over-restrictiveness and over-intrusiveness of parents. You also may know that most clinicians don't get a lot of training around family-specific techniques, and they may not feel that they are comfortable or competent or that they know how to juggle all of the different stakeholders. We tend to put a priority on internal transformation and the aha moment of insight, but that's not really a very youth-friendly concept in the sense of the way most adolescent learning and behavioral transformation takes place, or at least not the way it initiates, right? And so thinking about other ways, including external sources of motivation and external sources of leverage, I think could be done better. Traditionally, we've thought of families as being an enabling force, and we talk about parents, to parents about that. And I don't know if you've noticed, but when we say that to parents, what is it they hear? Whether we intend it or not, they tend to hear it's your fault and us blaming them, even if it's not what we meant. And then lastly, I think another barrier to family engagement has been an over-rigid application of our concern with confidentiality. And of course, confidentiality is a cornerstone of treatment, and it's appropriate that we should be concerned with it. But I tend to think that we've been over-rigid and not been able to be flexible enough about establishing how to do communication in a way that can get information that's usefully exchanged between young people and their parents in a way that will promote treatment goals. Families and youth don't have a sufficient recipe for treatment, in my experience. You need to give them a role. You need to give them definitions and expectations and responsibilities for who does what. Families have far more competence and natural leverage than we give them credit for. Sure, there are some families that are so toxic that you want to take them out of the picture, but that's usually the exception, not the rule. Most families have something at their core, and we can help them express that and implement them in a more proficient kind of way. I think it is not incompatible. That's a double negative. It is compatible that emerging youth autonomy as we usher them into adult independence, along with the concurrent empowerment of family leverage, both of those things can happen together. So we call in the Yours intervention, this family work that we do, the family framework, but that's just, our name for it. It is, I think, incorporates a number of features that are easily transportable to everyday work, even if you're not doing this kind of high intensity, highly resourced intervention. And the elements have included family education. You'd be surprised, or maybe you're not surprised, how little families tend to know about OUD and about OUD treatment and about OUD medicines and about their use. And we tend to do our treatment in a black box without being transparent to families. So that's a big element. A second thing we do, and this is at the core of it, is a three-way collaborative treatment plan between the counselor, the family, usually a parent, and the youth, setting the rules of the road about communication, talking about treatment schedule, talking about the uses of the medication, talking about how we're going to proceed, and setting the ground rules up front, getting all the releases signed up front, asking how will the family support attendance and treatment progress? How will the family support medications with a specific emphasis on medication adherence? And how would you like us to inform your mom if, God forbid, things don't go well? If you miss an appointment, if you don't get your medicine, if you have a slip, if you have a positive urine, what should we be telling mom? How would you like us to get her help? What are the criteria for pushing the panic button or calling the cavalry? Mom, how would it go in your family if things weren't going wrong? How would you guys use your typical family tools to set the trajectory right again? And most importantly, what's the backup plan? What's the rescue plan? If, God forbid, things don't go well, what's the next step? And what's the backup to the backup? And let's talk about it now up front in the brief moment of motivation at the beginning, before a relapse happens, before we're in lying and covering up mode. So we do lots of work educating the families about how to improve their negotiating skills, how to improve their leverage, how to pick their battles, that they've got to give to get. What do you mean I have to bribe my kid to do well? Well, now, wait a minute. Bribing is paying people to do bad things. This is rewards and incentives. And let's pick priorities. Keep your eye on the prize. You want to argue about the hairstyle, or do you want to argue about injection heroin use? You pick, but you can only have one or two priorities. And yeah, I know it's important that he clean his room, but maybe that's next week's goal. Right now, let's see if we can talk about abstinence from heroin, that kind of thing. And just to give you a sense of what we consider to be a poster child success story, and not everybody does this well, but a patient who was a 21-year-old male with a long history of injection heroin, injection fentanyl. And he was a person who'd been in and out of rehab. This was his 5th inpatient detox admission over a year and a half. And each of those times, 5 times, he did get a first dose of extended release naltrexone. In a brief nanosecond of motivation, said, yes, I'm interested in that treatment. And that was very encouraging. But each of those times never got a second dose, never kept an appointment for outpatient treatment, each time dropped out and relapsed. So this next time, he was enrolled in one of our studies for the Yours intervention. And grandma was the treatment significant other, the TSO, the parental caretaker, and we got her involved. And we went out to the house to give him his second dose. And true to course, like before, he changed his mind and his motivation had waned and he wasn't sure. And he said, no, thank you. I don't want the medicine. I'm fine. The door is over there. But this time, rather than us being the only force for persuasion, we had grandma directly on our team, and she had this kind of parental authority and relationship alliance that we could never have. And she said, no is not an option. You're getting the dose. And she had the juice that we could never have. And then it was a done deal, and he did very well and got 6 consecutive doses over the course of a 6-month intervention and did fine. And as I say, not everybody does this well, but this is exactly the kind of thing we're looking for, is to build an alliance between the parental caretaker, the young person, and us to try to get on the same page for common goals. And I'm going to quit now because I know that the conversation, I won't show you the data, but here's some references and you guys can have the slides, but let's have the conversation. And Dr. Hennessy, if you'll lead us, I'd be happy to talk more about any of the particulars.
Great. Thank you. Can you guys hear me? Yes, you can hear me. Okay, so thank you so much, Dr. Fishman. That was very informative and very helpful information. And right now we have one question in the chat room, which kind of mirrored a question that I was going to ask you. So I'm going to go with that one. And this question is from Gail Gorin. And she asked, have you encountered parents being the obstacle to long-term MOUD treatment beyond the first or second months?
We certainly have. There are a number of ways in which that might happen. Sometimes there are parents that say, this is just a crutch, this is not true recovery, I don't want your stinking meds. We've certainly met parents who have their own personal recovery. Medications may not have been the path that worked for them, and they're skeptical and suspicious. So we do get that. I will say, though, that parents that are motivated to try to help their young person and are available for engagement, even if they're not the biggest cheerleaders for the medicines, if they're cheerleaders for recovery, I want them on my team. And it's okay to take some time and to gradually bring them on board with the particular goal of the medication. And for most of the time, we can at least get to neutral, which is, all right, I'm not sure I believe in medicine, but if it's what he wants and it helps him, I'll support him, whatever he needs. And that mostly works. We don't end up usually with parents whose only objection in an obstructive way is the medicine. Now, we do get parents, and again, it's the exception rather than the rule, but it does happen, who are toxic in the sense that they may be in active addiction and wanting to share drugs with their kid. That's a non-starter, and that's not the right parent for the intervention. We'll try to get you your own help. Is there a grandma or an aunt or somebody else or a close friend or a significant romantic partner of a young adult? Probably the biggest issue for us in terms of problematic parents are absent parents, the ones that are hard to engage at all. Not so much that they're oppositional, but they ghost us. And we want to bring them in, and we spend a lot of time trying to call them and write them and send them messages by carrier pigeon or text them or whatever it is, and we just can't get them to engage. And so we make do without, or we try to find other sources of adult support in that person's life. Sometimes successful, sometimes not.
Thank you. So going off that last part that you had mentioned, because you also had said during the talk about having the second plan and the third plan, do you try to engage more than one family member to be the cheerleader, the support, to make sure that they get their treatment? I realize that may not always be possible. And of course, sometimes kids have guardians rather than parents, but if it's possible,
are fine too.
Yeah, no, absolutely. But do you try to just engage as many people as possible, or do you try to focus more to one, or say one person who's the primary, like the grandmother that you mentioned in the case?
We've tried to pick a primary so as not to muddy the waters and have too many chefs in the kitchen, but we certainly do try to get a backup and say, well, if this person says no, or if this person decides to pull out, or if this person's not doing well, who could be the second person we go to? When a young person has separated parents and both want to be involved, we try that balancing act. And then sometimes we end up doing more family therapy among separated parents who have different ideas and want to fight their own battle over the kid. I know that shocks you. You've never seen that before. So we try to navigate that sometimes. But the main idea is to at least find one champion who can be in the kid's corner.
Thank you. And if there is a situation where the parents are very resistant, you had mentioned, you gave examples earlier, are there techniques you use, or are there ways you try to deal with that resistance? What do you try to teach them? What kind of interventions do you use about the medications, but also really not about the medications, since much of our audience is doing counseling as well?
Sure. So as you mentioned, one of the things is to educate about the medicines, that they are safe, that they have certain effects. We try to make sure that we're not overselling it. We don't have the penicillin for opioid use disorder. This is not curative, but we think that this can help enormously, and anything you can do to influence the receipt of the medications. But absolutely a broader set of educational efforts about other areas. And one of the things that resonates the most strongly is to try to help them improve their overall impact. A lot of these youngsters are actually living with their parents, not all of them. Some may go to recovery houses, or some may live independently, or the like, but a lot of them are living with their families. And when the families first present to treatment, they are so embattled and so chaotic and so at a loss. And the families say, I've tried everything and nothing works. And everything we do is rejected, and everything we offer is rejected. And I can't make any sense out of this. And they never listen. And of course, the kids say the same thing about the parents. They're always nagging. They don't approve of anything I do. They never praise me. It's the same kind of embattled thing back and forth. And one of the biggest impacts that we find we can have is to broker that and try to improve communication, so that both the adult in the house sees a path to picking a priority goal and having leverage for the most important things, and perhaps letting other things go, and that the youth in turn sees an opportunity to get support and praise for the incremental progress that they make, even if it's short of perfection. Because everybody usually has unrealistic goals by the time they get to us, and they're up to their ears in alligators, and we try to de-escalate. And if we're successful, what we hope for, like with all family treatments, is that the lessons learned of being able to communicate in a family system will transcend far beyond our involvement, and that they will be tools that they can keep going even when we're no longer in the picture. They may fire us, but if they've learned anything about how to communicate with each other, then the idea is that that's a kind of a sleeper intervention that has long legs.
Thank you. Are there particular community resources? Obviously, states are different and communities are different, but any national resources that you might recommend for the parents and for the adolescents as they're coping with their substance use disorder themselves, or the parents coping with the adolescent?
Well, I love the resources that are on the partnership website, and I'm sure that we've got those posted somewhere in the materials for this series. Those of you who don't know, the partnerships got videos, got printed materials, got people available live to chat and the like. A lot of very good emphasis on parent-facing instructional and educational materials that are very good. I like a lot of the stuff that's been written by Bob Myers out of University of New Mexico. He is one of the people who has publicized a family engagement technique that he calls CRAFT, Community Reinforcement and Family Treatment, which informs a lot of what we do for sure. Those are two biggies.
Okay. Thank you. We have a question from the audience. Karen Carlini put in a question. We are a long-term residential treatment program with outpatient aftercare available after residential. We have a robust family program that begins on day one. We also see that it is important for the young person to have positive peer reinforcement. Has this been studied?
Nice. So more power to you. We have had, just in our hands, difficulty generating a lot of sustainable peer work. And we've tried both in the sense of youth peers and peers of families. Both of those ideas resonate very strongly. And if you've got actually a bunch of tips, I want to hear from you about the things that you found to be successful. We found it's just hard to schedule people together. and hard to get either youth peers or family peers to sustain involvement more than just a little bit. But maybe that's just because I'm not a great community organizer. So I think that your notion is a very powerful one. And like other people who talk about it and have had success, I think a very powerful one. There isn't much scholarship on it. There isn't much research. There's an extensive body of emerging research in adult peers and recovery coaches and that similar kinds of intervention, but not that much written about youth, as far as I know. Be interested in hearing, some of your tricks.
Yeah, well, actually, Karen Carlini wrote, "We'd love the opportunity to discuss further." So
Great.
If there are some ideas, the other questions are coming in, but maybe we can figure out a way to get connection in that way after we go through the rest of them. So Eileen Connolly put in a question, is there a study of what happens to the individual after they stop engagement with medication?
There's certainly a very large body of work with adults. And just to summarize that, unfortunately, most people who stop MOUD relapse. Now, it's not 100%. For sure, there are a subgroup of people who stabilize for a time on medications, and this is true for all three FDA medications, FDA-approved medications, methadone, naltrexone, and buprenorphine. People who stabilize, who stop medications, and continue to do well and continue to improve on their journey in recovery. But it's the minority, and B, we have very little ability to ascertain prospectively who are those people who will succeed and who will not. So there's work in the field that's being done on that, but it's poorly understood. In terms of young people, specifically, even less is known about prospective selection of who are candidates for shorter term medication treatment as opposed to longer term medication treatment. So all of that adds up to the rule of thumb when patients push and push and push. I tend to try to avoid the conversation and say, let's just get you on medication for now. Let's just stabilize you for now. Let's not use a chronological clock. Let's use a functional clock. What does that mean? That means that we get you back on your feet. You get back the things you've lost with the legal system, with the family relationships, with co-occurring disorders, with your employment, with your school. And then we'll talk about getting off the medication. But for right now, we're trying to get you on the medication so that you can do well. Oh, okay, Dr. Fishman, that makes sense. But really, how long? And then the answer is as long as you can, because we know that duration of treatment and retention on treatment and adherence to treatment correlates with longer term success. But again, that's mostly adult research and has not been done in 15-year-olds, in 19-year-olds. And so that work remains to be done.
Thank you. And we have a question from Patricia O'Gorman, who asks, have you used NA, Alateen to develop peer support?
Yeah, and as you guys know, 12-step approaches are not for every young person, but for many young people, especially when they are youth-specific and youth-welcoming 12-step groups, it's a modality that is very, very helpful for many teens and many, many young adults. So we encourage it as best we can. And in that sense, in a mutual help setting, people develop their own support group and their own resource set of peers, whether those are same age or close age or even not same age. And for sure, that's a great way of finding a recovery peer set. We do, though, have a subset of youth who reject mutual help and self-help. And so that remains a bit of a gap in where to find suitable supports. I think youth-specific recovery housing, when it goes well, is a potential element to the treatment intervention continuum that needs to be explored more because youth tend not to do as well in adult-style recovery housing in at least two ways. One is that they don't get sufficient supervision, and in another way, they almost get too much restrictive supervision because adult style rules tend to get applied rigidly, and then the young people get into the standard young person's mischief and get thrown out for having their girlfriend hidden under the bed. And although that may be against the rules, it's totally developmentally normative. And so how do you work with that kind of rule breaking in a way that doesn't get them dismissed from care? Anyway, more work needs to be done there. And the few examples I've seen of developmentally informed recovery housing programs as one element of the support network that you bring up, I think needs to be expanded. But it hasn't been well studied for sure.
Thank you. We have 3 questions left, so we'll probably do those and then we'll need to wrap up. Trevor Payne asks, any insight you can share when treating adolescents of different racial and ethnic groups?
I think just the standard things that one would say about cultural sensitivity broadly, that learning to speak other people's language. I don't necessarily mean that literally, although it could be literal if they're not English speaking, but I meant their cultural language and learn what they're interested in. And this is true of any ethnic group or any racial group. Take the effort to understand something about what their communities are like, what their lives are like, what their families are like. And that earns you, I think, a lot of credibility and a lot of capacity for engagement that you wouldn't get if you just assumed that everybody is homogeneously exactly the same, which we all know is not the case.
Thank you. Dr. Fishman, I know you're in Maryland, but Elin Dolmo, I apologize if I said your name wrong. He was wondering if you were aware of any programs in New York City that helped, any services in New York City that helped, sorry, my questions are everywhere, helped assist parents in the recovery with their young adults.
I apologize, I'm not up on New York State or New York City based resources, but Dr. Hennessy, you and your team at OASAS will probably have better answers to those matters. And so maybe the answer is to get in touch with the OASAS team, who will know what's on the ground all over the state.
Yes, yeah, no, definitely you can check out the OASAS website. I will see what I can find out as well. In the full interest of disclosure, I have been working for OASAS for all of 4 months. And before that, I was with the VA and the federal government for many years. So I'm still on my steep learning curve with all things OASAS. However, I have no doubt our friends at the partnership and Maria Morris could perhaps help us with that. And I might give them a minute or two to jump in before we go. But I did want to get to one last question, which was a little bit different, that I tabled, and I appreciate Bill Lillis's patience. He asked a little while ago, can you speak to the connection between use of marijuana as an adolescent and how that possibly leads to opioid use disorder?
It's a great question, and I wish I had a richer and more sophisticated science-based answer to that question. It's something that we struggle with constantly. As you know, most of the youth we work with don't think of cannabis as a drug or as a harmful drug. It's a medicine, it's a legal substance that everybody does. It's what helps me get through the day. Why are you fussing at me, Dr. Fishman? If I'm using injection heroin less and smoking a little weed or a lot of weed, what's the big deal? What's all the fuss? And our broad clinical consensus, many of us who do this work, is that you have a number of problems with continued use of any non-opioid intoxicant if you're looking to maintain abstinence from opioids in the standard kind of way that all of you as experienced clinicians know. First of all, disinhibition with intoxication means bad choices about risk behaviors, and you get yourself into situations intoxicated on alcohol or cannabis or benzos or cocaine that will unfortunately lead to relapse to opioids more than you would intend. That's number one. Number two is that reinforcement of any intoxicating cyclical behavior encourages the same psychological and brain-based drive and reward mechanisms that got you into trouble in the first place. We think of SUD as a broad continuum of illness. Sure, opioids are the more advanced malignant stage. And yes, I concede nobody ever died of a cannabis overdose the way people die every day of fentanyl overdoses, but that's not the point. It's an earlier stage that continues to reinforce the same kind of narrowed repertoire of behavior and the sledgehammer overtaking of the brain's reward system by an intoxicant rather than all the other alternatives in a rich, full, non-intoxicated life. All of that is very hard to sell to young people, and it's very hard to demonstrate in the data. So we have not yet had good and convincing data. Not that that kind of data is going to change the behavior of a 15-year-old, but it would be nice for us to have clear and convincing evidence that there is a dose response cannabis use relationship to opioid relapse. I suspect it's there, but it's an empiric question. So we need that work. But in the meantime, I think the kinds of arguments that you, I'm sure, use in your everyday clinical work and that I started to outline are the reasons why we would say to young people, as hard as it is for you to swallow, at least for now, and I tend to do it this way. I'm not saying you should never, ever, I don't ever talk in absolutes, that you can never use cannabis or you can never use alcohol again, because that's a deal breaker, even though the bubble in my cartoon is that that's what I think. But for now, while you are trying to stabilize your life, it's not going anywhere. For now, let's see how much better your life can be with total abstinence. But I recognize that improvements and reduction in use short of total abstinence are still worth having, are still to be celebrated, are still incremental advances. But the gold standard, the light at the end of the tunnel where we're trying to get you to is full abstinence. But again, in this current culture where cannabis is considered no big deal, that's a hard sell. But the right sell.
Absolutely, absolutely. Thank you.
Well, this is Maria, folks.
Hi, Maria.
I just wanted to say a couple of quick things.
Please.
One, if you go to the OASAS website and look under the regional resources, you'll find information on family navigators that are there to help assist families in navigating treatment and recovery for their young people. In addition, you will also see a piece that talks about peer navigators, as well as our regional recovery resources that are the recovery outreach and centers, as well as the youth clubhouses. And then finally, and most importantly today, I want to thank everyone for their participation in this series. A special thanks to our special guests, Dr. Fishman and Dr. Levy from last week, and a very special thanks to the medical team at OASAS, Dr. Mark Manceau, Dr. Grace Hennessy, and Dr. Kelly Ramsey. We couldn't have done this without you, and we appreciate the support in addiction treatment and recovery. And then the other folks that are our unsung heroes behind all of this are our partners at the Partnership to End Addiction, specifically Luis Torres and Mithras Salamisi, who helped organize all of this and put it all together and keep us on track. So just a special shout out and thank you to them for a job well done. And we will work closely with them and get this material posted quickly. And we look forward to being with all of you, hopefully sometime next year in person, so we can continue the important dialogue and discussion that we began with this series. Thank you.
And thank you again, Maria, for jumping in and helping with that question. I didn't know how to answer, so I'm grateful to you for that. And I'm just going to echo the thanks as we come close to 1 o'clock. I want to thank Dr. Fishman for his thoughtful talk and for his time today, and especially to the audience. There were some really great, thoughtful questions that you brought up today. So we're very grateful. These seminars don't work without you. So again, I'm going to thank everybody. Have a wonderful day. And as Maria said, information will be posted as time goes on. Take care.
Thanks all.
Mm-hmm.